All right. How do we click forward? Yeah, that's fine.
Hi.
Hi, everybody.
You're on.
All right. So, happy belated birthday, America. On this 237th anniversary of our founding as a country, Lesley and I wanted to highlight a couple of themes related to government and its relationship to the private sector. I'm here from Washington. I'm here to help, representing the Fed side, and Lesley's representing the nonprofit and private sector. And you will note that we are doing this presentation very much together. That's kind of foreshadowing a big takeaway here. And to further point out where this is going, I want to quote one of our founding fathers, Ben Franklin, who said, "It is undoubtedly the duty of all persons to serve the country they live in according to their abilities."
And so we not only carry forward that theme from Ben Franklin, but we also know that in our Constitution, it says that the concern of government for the safety, for the health, peace, and morality and safety of its citizens. That's what general welfare is, and it's in the first paragraph of our Constitution. So healthcare reform was needed. Why? I think things have had a very slow network effect in healthcare, right? The hoarding of data, the proprietariness of systems. We have not created a network effect, yet we need one desperately. And so healthcare reform came upon us.
Healthcare reform is taking place within a context that I would argue is something of a perfect storm of opportunity for change. And I think that Vince painted some parts of this quite nicely. You've got health reform and at the same time other changes in the policy realm through meaningful use policy, the incentive program for EHR adoption and use of the content and exchange of the data therein. We've now got more than half of healthcare providers using EHRs. This is a key tipping point, and more than 80% of hospitals. This is huge. Again, we've been crawling along for years, and finally we hit that tipping point. So this is going on. And at the same time, IT, of course, information technology, again, referring back to Vince, is getting better, cheaper, and faster. It's partly about mobile phones, as he was discussing, but increasingly, too, there are sensors in everything. I'm wearing a sensor around my wrist right now, and increasingly we're going to have things that help to inform us about our environment and our bodies. And at the same time, social media is changing things radically. Back to the discussion of connecting patients and others to themselves, this is changing the model of how we think about healthcare, because it's not just about accessing someone else's information, but it's about creating information and interacting with others, just as we do on Facebook or Twitter or other sites.
So consumers aided by technology will be totally transformed. Know why? It's not just being educated about our health, but it's also having the opportunity to know something we didn't know before, to have access. It's really liberating. It's really important for us to be able to have this idea that we can contribute. We are part of a solution, because transparency does just that. Transparency is part of our fundamental reason that our government has succeeded. And it's largely because we insist on knowing, we insist on being involved, and our government transitions every 4 years, peacefully, quietly, and, well, sometimes loudly, but with great opportunity for new engagement of new ideas. And we think that that's just what's happening here, is a revolution. A look at the past.
We have here a joint study undertaken in 1961 with the International Business Machines Corporation for the purpose of determining if it was possible to eliminate the paperwork, or at least part of the paperwork, which has burdened the nurses and doctors in hospitals for these many years. In 1964, 15 input and output terminals were installed throughout the hospital. 7 of these were put at the nurse's station and the balance at the ancillary department. These terminals have many purposes. The one in the admitting department is to record the indicative information on each patient as he is admitted and then transmitted to the patient's floor. The terminals on the floors record the information and the orders for medications and tests as they are generated at that floor and as written by the doctors and nurses. This information, in turn, is sent to the central computer and is then related back to the ancillary department involved. Now, so far as drugs are concerned and orders of this kind, the nurse at the desk is reminded at a specific time of day when she should give the drug and in what amount. In spite of the relative short time that we have been working with the terminals, we now can see certain advantages that are taking place. It is going to be possible to relieve the nurses and the doctors of some of their paperwork. It is going to be possible to have correlation of diseases which we have not had before. And it is going to be possible to eliminate errors in medications and in tests of this kind, which would have been harmful to the patient.
The reason is we've got the most inefficient healthcare system imaginable. We're still using paper. We're still filing things in triplicate. Why wouldn't we want to put that on an electronic medical record that will reduce error rates, reduce our long-term costs of healthcare, and create jobs right now?
So really, the role of government, going back to general welfare, is really to promote health safety, to promote our own welfare. And yet, look at the promise, 1963 with that IBM. Market didn't resolve this in its own way, did it? We needed some help, some forced innovation and some forced interoperability.
So I wanted to talk a little bit about how we who are in the government right now see our role. Obviously, through meaningful use and through health reform, we're doing a lot of things that are meant to push things forward with incentives or changes in regulations. But in addition, and particularly when we come to this theme, which Lesley and I are going to be touching on a lot today, of engaging patients and consumers in their own health and healthcare, we see ourselves as really catalysts and conveners. And we listen and learn from others, but we really believe that it is members of industry, members of the private sector, certainly the foundation sector, but also patients and consumers and caregivers themselves that are ultimately driving this movement forward. And so our role is to help facilitate that process and encourage it to happen as quickly as possible.
How many of you are aware of the federal advisory committees? The Health Information Technology Policy Committee and Standards Committee. So a good chunk of you. Well, guess what? These federal advisory committees are the people making the recommendations for meaningful use. It's industry leaders. It's people who, like us, like me, who are involved in making these decisions. And I came to DC at first with skepticism, with a concern that, oh, heck, what's going on here? And who are these bureaucrats? Being involved in the federal advisory committees, the S&I framework, and other areas has really taught me so much about access to government. The ability to influence decisions, the ability to have heated discussion and argument, to challenge assumptions, to be involved. So if anyone feels victimized by meaningful use or victimized by what they perceive is happening by government, it's your own fault. Because you have an opportunity to participate and an opportunity to have a voice at the table. And my experience is that it's listened to, it is included, and it is worked upon. So I have been very much engaged, very involved, and very optimistic by the participation in these efforts.
And I just want to say Lesley has made incredible and continues to make incredible contributions to the work of the federal advisory committees, as do numerous other peers of hers. The federal advisory committees are one avenue for public-private collaboration. There are certainly others. Another example is something that is run out of my office, the Office of Consumer eHealth, called the Blue Button Pledge Program. And this is entirely voluntary. And through it, more than 450 organizations have signed on and said, we are going to volunteer to give patients direct digital access to their own health information, whether they're providers or whether they're health insurers or labs or others who hold patient data. And or, depending on what kinds of entity they are, they're going to help spread the word, because that's just as important too. So we have organizations that have pulled together and motivated and put together some pretty impressive outreach campaigns, as well as building new tools for consumers. And one of the things that unites all of these folks is this participation in the Pledge program.
There's been other efforts as well. The National eHealth Collaborative, which was an ONC-funded organization, we've developed a patient engagement framework, which I'll go into during our sessions, that has really set out a roadmap for health information technology to support patient engagement, and has actually been downloaded over 10,000 times. We had no idea when we did this how much of a void there was in the market that just said, where is health information technology going for patient engagement? How is it aligned with meaningful use? Where can we look to get guidance? And although it's not the right answer, it's a start. It's the first answer. And we hope to iterate on this over and over and over again so that we can get more information and a better alignment for health information technology and patient engagement.
As a final example, just last month, we held a meeting at the White House pulling together members of the private and nonprofit sectors and said, how can you help us to drive forward patient connectivity to data? And really just pulled ideas from the groups. And as a result of that, we're going to be having a variety of efforts that are going to be open to the public to participate in to do specific things like run a nationwide consumer outreach campaign and figure out how to more clearly articulate some of the policy requirements for providers and for other parties, such as developers, that are related to consumer engagement in eHealth.
Let's hear from a patient's point of view on this.
That even though the patient in our system in America is kind of the gatekeeper of the information, there's no documentation of the patient's voice within these medical records. And that's really, it can be really demeaning and demoralizing, and I think very unhelpful in helping physicians figure out what's going on in your case. I'm the only one who knows what it's like to have the brain bleed inside my body. I know how I feel in chemotherapy. I know what it was like to be in the coma. I know what it's like to have the hemangiomas. So I have really valuable information that nobody else has. And there's no place in our medical records that that voice is actually documented. And that's really frustrating to me. Because I want to be a part of the group. I want to be inside the circle. I want to be talking about it. I want to figure it out. I want to live. A person is involved and understands the purpose and the intent behind what is happening and is a part of the decision-making process, then they are much more likely to do what they say they're going to do.
So engagement can help to heal us all.
What would be really great would be to have an interactive electronic medical file so that when they're trying to help me or to be current upon what's happening in my life, they could just go to this place where I had all my records in one place. And so they could hit a button for MRIs or for CAT scans or for the blood test or for doctor's visits, medications, all that to keep them up to date. And this would be really crucial for my non-Western caregivers as well. So the person I do acupuncture with, for them to be able to have this access and collaboration between Western and Eastern medicine, which would be really awesome, as well as a place for the patient's voice, if a patient chooses to insert their information there. So
what this tells us is we have been dwelling on the transactions of health with data systems. We really need to be focusing on the collaboration and co-production of health. And we've somewhat done the wrong thing well. So now with getting the patient involved, there's new opportunity for work and new opportunity for each of you to be involved.
The big takeaway here, the theme is collaboration and partnership, and that applies on two levels, both, of course, the patient and provider level, and then also on the private-public sector level. So that's really the big takeaway here, and there are numerous areas where we need greater involvement. We as a whole, and I speak almost not as the government, but for all of us jointly, we need to work together to solve these problems. There are a couple we've talked about and a few others teed up.
Yeah, we were really excited about the blue button and access. Access changes everything. We also know there needs to be new policies so we harmonize efforts for patient engagement and technology so we don't end up with the same sort of quagmire we have today with interoperability of healthcare systems for the providers. How many providers go to 15 different portals? We don't want that. It's just like Vince said, individual portals actually marginalizes the network effect. We're also working on direct email to patients so that it's a secure and private way to provide messaging to untethered PHRs, care planning and care coordination, and patient-generated data.
So if you want to learn more about what's going on in our public-private collaboration and you want to be a part of it, please participate in our track later this afternoon and tomorrow, and find other opportunities online and elsewhere to be part of the conversation and part of the process. As Thomas Jefferson said, whenever people are well informed, they can be trusted with their own government. And that really works on many levels. So Uncle Sam pretty much says it all. We need you.
So thank you. You have questions.
Oh, great. Hi. Thank you. Yeah.
I'm thinking about the comments before about the patient network and how powerful that is, especially in impacting what the government hears and learns. We're self-organizing people, humans, and I am seeing rare disease groups aggregating across the globe to instruct, and not only rare disease, common disease, so that they can instruct their healthcare provider on what the rules and standards should be for that disease management. And that is very powerful, and a great example of government collaboration and network effect of the patient network is now a demand amongst the Heart Association, Kidney Association, Liver Association, different groups for opt-in versus opt-out on transplant, an example. Mm-hmm. These people getting together through social media and coming together saying, if we're an opt-out country where we said, no, I don't want my organs donated, we wouldn't have the problem of that 10-year-old little girl going on. That rise of patient networking and collaboration of people awaiting transplant, coming up in the rare diseases through social media, technology, informing government as to policies. I thought it was a great example, and I wanted to get the plug in.
It is a great example, okay. But I want to ask a question of the group. How many of you believe that preference-sensitive care is a lower number than evidence-based medicine? So do you know the difference between the two? So evidence-based medicine tells us there's a large body of evidence that says this particular treatment, practice, or test has evidence associated with, shows that if this is done, we have a high degree of positive outcome. And as providers, we might often look to evidence, correct? And as patients, we hope that there's evidence. But in fact, the majority of care is preference sensitive. Now, what does that mean? It means that your values, it means your direction as a patient, it means your biases, your indications, your goals have as much or perhaps more to do with the outcome than the evidence presents. And yet, we don't see the options, understand the options, or participate in the option. So I think one of the greatest opportunities for transformation comes when the patient has access to the record, has education about their information, and can start participating in choices where their values preference and direction has as much to do with their outcome. Most of us don't understand how powerful we are in the decision-making that goes on in healthcare today because we trust that the evidence will guide us. It's just not there. Agreed.
So about your general question about an approach towards standards, that's exactly the approach we've taken, actually. It's saying, like, these are the general requirements to figure out how all these different systems can continue to compete and to connect to one another at the same time. But we're not forcing anyone to, radically change what they're doing, except that it needs to follow these basic parameters so that information can be exchanged. So philosophically, I think we're all on the same page.
In fact, standards are the most liberating thing that we can have happen in health information technology. And with government promoting these standards as part of meaningful use, every EHR has to live up to them. So with meaningful use too, every electronic health record will have to support direct messaging. Every electronic health record will have to support view, download, and transmit in the blue button. Every electronic health record has to support patient education. Every EHR has to support the ability to create an after-visit summary that identifies to a patient all of their care, and every transition of care provide information to the patient. So these are changes of certification and standards that will enable the public to participate in their own healthcare in different ways. The ID issue is one that always gets brought up. The example of Commonwealth's first efforts to try to come up with agreement, not necessarily on just the master ID, but the principles that guide the algorithms to determine whether or not this is the correct person. The average physician office misidentifies a patient 38% of the time, and yet the incentives for them to get it right means they get paid 38% of the time in their office. Imagine now connecting to hospitals, health systems, and others. So patient identity is an issue. Opportunities in the market will come forward. I do not think government will mandate a national ID. There are things that
I have to say, actually, government is actually precluded from mandating a national ID due to a number of discussions that came up during the passage of the HIPAA laws. It's off the table that any government agency invest any funding in pursuing a national ID because there are a lot of privacy concerns around it. But there are a lot of, I think, other technological solutions to the problem.
What we're hoping potentially is that a patient's direct address at a high level of assurance with good digital security and trust could be a proxy for a patient ID. We don't know, but I think that the idea of hoarding information to sustain a particular market didn't work for AOL, didn't work for MySpace, hasn't worked for just about every other industry where technology has come upon them and brought in the consumer or in our case, the patient. It's just untenable. And the CEO that says, I can't make any more money by sharing their information is just simply an idiot. There's just no other way to say it, because you will actually make more money. You will actually align people better if you anchor the community and you center it around the individual patient.
So I think we have to wrap up. I think we can take one last question. Yeah.
We're out of time. I'll be very... Is it on? Mm-hmm. I'm Diane Weiner from Hilarium. I just want to challenge one statement. When you listed the must-haves that an EMR needs to do, there are technology companies and innovators who are extending EMR capabilities. And so I hope that when you said they have the must-haves, you weren't only talking about internal development.
No, I totally agree. I think it's not going to come from internal development. And I think that the opportunity for a new platform of health, as Vince talks about, is a real one that standards will enable. But frankly, if we wanted to automate health and health collaboration, would we have ever started with an electronic health record? We did the wrong thing well. Well, not that well. But now we are coming in with a new platform opportunity that says, how do we automate collaborative health? How do we co-produce health? Because we've done not a good job of recording illness and then sharing that and calling that nirvana. It's a start, but we have to get the plumbing connected to see these kinds of innovations rise.
I would also add that we need to think about health more broadly than health care. That has to be a really big transformation, that we've been so obsessed with treating sickness and treating episodes, and we've got to, through technology and through engagement of consumers and patients, move toward a world that's more about prevention and holistic ideas of the body and the mind, actually. So do join us in the next day and a half together in continuing the conversation.
Thank you.